Very well. Thank you, ladies and gentlemen. We really are humbled and privileged to have Mr. Edwin MASESE, who will walk us through the role of rapid diagnostics in enhancing antimicrobial stewardship, with the main focus on syndromic testing and on a molecular platform. He's going to shed more light on the possibilities of running bacterial identification on a positive blood culture. Without much ado, I welcome Mr. Edwin MASESE. Please take over.
Thank you very much, Mr. Kamau Gatechi, my good friend and colleague, and my senior professional colleague. So as you heard, my name is Edwin MASESE. I'm a lab scientist by profession and biased in molecular biologist. Molecular biology. And today, just going to take you through some of the new developments on antimicrobial resistance, or rather antimicrobial resistance stewardship, and some of the, or rather one of the latest technology in diagnosis of resistant genes, and one of the quickest way of doing the diagnosis on the same. So without much ado, I know most of you already know what is antimicrobial resistance, and today I'll majorly focus on blood because it's one of the key samples in the lab. And whatever that maybe I'll not be clear, let me know and I'll be able to respond on email, or we can be able to respond immediately if possible. So you can be free to share your comments, your compliments, your queries on the chat box, and my colleagues will be collecting them and we'll be able to answer them as we go. So as I said, today I would like to, So today I would really want to focus on blood infections. And when we're talking about blood infections, what is the definition of a blood infection? We can say sources of infection. Could it be bacteria? Bacteria enter the blood, leaking the blood vessels, organ dysfunction, and later get death. So, but in summary on the same, when we're discussing about bacteremia, the presence of bacteria in the bloodstream, and as you've seen in the diagram, that's like the life process of the bacteria. But in this case, we are discussing not necessarily only about bacteria. We'll also briefly look at fungal infections and how they might cause this almost the same process. So when we are looking about bacteria, we may end up getting something like a septic shock. And most of you already know what we mean by septic shock. These are conditions that can occur in severe sepsis where blood pressure falls and organs fail to receive the sufficient oxygen, or rather the oxygen needed. But in this case, our main question should be, is it all bacteria or fungal infection lead to sepsis? And how can you do that quick diagnosis? So in my presentation, we'll also quickly look at the current method and the previous method, or rather what we call the conventional, and like the latest ways, one of the latest ways we can be able to do this diagnosis. So again, are we looking at viral, fungal, or only sepsis? And is there a way, because most of the time we only look at one organism and you go through with it, but could there a chance be that you are missing either that viral infection or that fungal infection or that bacterial infection? So that's why we are saying, although less common, viral and fungal infection can lead to sepsis, which can include the viral, and you know about things to do with influenza, herpes simplex, for example, adenovirus, SARS-CoV. When you talk about fungal, it could be aspergillus or candida. And some of the common infection in adults that lead to sepsis, you can see lung infection comprises of 35%, quite risky. So are we able to really do that diagnosis? And I know our discussion is the latest technology, but I'm just doing a bit of a background on the same so that we understand where are we getting this antibiotic resistance. So if you look at the urinary tract infection, it comprises of around 25%. Gastrointestinal infection comprises about 11%. And skin infection, again, another like 11%. So most of the, I can say common bacterial sepsis in sepsis are Staphylococcus, Escherichia coli, and Streptococcus. And again, if you look at the signs and symptoms of sepsis, in this case, confusion and disorientation, you may have shortness in breath, high heart rates or low blood pressure, depending. So that will depend on how you are looking at it, or depending on the doctor or the patient in front of the doctor. It could also be fever, shivering, or feeling cold, pain or discomfort, clammy or sweaty. Or on the other hand, when you're looking at all this, now the confusion comes in when you have almost all of these symptoms. Yeah, so that we are saying one of the new technique is when you're doing a syndromic approach. And when you talk about a syndromic approach is we'll try to combine all this, and also in terms of organism, again, we also try to combine all the organism and do at a PCR level, we can do something called the multiplexing and detect like all, combine all these organisms and detect them in one. But who is at risk of getting that sepsis? Is there anybody at risk? We are saying it can cut across, but in a nutshell, we can say people with chronic condition, sepsis survivors, people with recent severe illness or while hospitalization. Again, we know people with above the age of 65, of course, the immunity is compromised again. So they're also at risk of getting such infection. Again, children below the age of 1 year, again, for reason known to all of us, again, the immunity is not well built up. So again, they're also at risk of getting such infection. So let's look at a global health crisis. So what are we talking about this? The need for speed. If you look at the mortality rate, the increase is at around 7.6%. So, and again, when you're looking at some of the global recommendations, the reduction in sepsis mortality and also contribution to antimicrobial resistance. So how does this all come together? So the need for speed, and that's what we're saying, one of the recent technology in diagnosing sepsis, which might lead to antimicrobial resistance, is actually employing one of the latest technology. And if you look at the current recommendation, as many as 80% of sepsis cases could be prevented with rapid diagnosis and appropriate treatment. Again, we are saying if you treat sepsis in a timely manner, we can save lives and curtail hospital costs. Again, the current technology, which I'm not despising, is still the gold standard for something, as I said, blood. For something like a blood culture, all of us know, how long does it take before you have a comprehensive report? If this patient has been on medication, for example, how will you be able to tell that probably, or maybe the patient is on medication and you take that blood culture for diagnosis in a lab? So how sure are you that you missed the target, probably because of this patient has been on medication? You know our techniques currently. So those are some of the things that I'm trying to bring you up to speed as compared to what we'll discuss. So quickly, let's look at the current testing. We've already looked at sepsis. It's one of the topics that I was saying. Next time, probably we'll discuss the same when you're talking about a sample like sputum or chest infection or pneumonia cases or respiratory cases. And especially for pneumonia, next time probably we'll discuss on lower respiratory tract infections. So how do we do the misdiagnosis in relation to recent technologies in diagnostics? Okay, so if you look at the current test, first, you look at the sample collection. The whole process may take up to 24, you look at my slide, 24 to 72 hours. So if you look at the current testing, the sample collection, so how is the sample collected? So the blood will be collected from the suspected patient. Of course, we all know this. The number of microorganisms present in blood could be less than 1 to 10 colon forming unit by ml, depending if it's a pediatric or an adult. And again, you're supposed to collect using a sterile technique by peripheral or line draw. So, but how do you tell that this blood is enough? Again, some of the queries which we are talking about, how do you tell that this is the recommended volume? The way you collect, the kind of tube that you use, all this contributes to what we are talking about. So for blood culture, again, if you look at the blood culture, the same thing which I've already discussed, you look at the bottles, the volume, how was the blood collected, and so on. When you come to the second stage, of course, for blood culture, the moment probably you've identified you need to do a gram stain. And we all know when they talk about a gram stain, what is the definition of a gram stain, and how does it help, or the technique, how does it differentiate from chemical and the physical properties of an organism. So in a nutshell, if you look at my presentation because of time, if you look at the gram stain vis-a-vis in terms of gram positive and gram negative, the differentiator is a peptidoglycan layer. And if you look at the gram negative, for example, of course, all of us know the gram negative normally don't have the peptidoglycan layer, and the gram positive have a thick peptidoglycan layer, the one marked in purple from my presentation. Now, the reason why I'm taking you through this is to appreciate the current method of diagnosis using the normal protocol. So the gram stain itself, you have to do the microscopic view. Remember, this one you've already put for example, the blood in your oven. Sorry, not oven, in your incubator or blood culture machine if you have it. Then when the blood is positive, you do the microscopic view, do the gram staining process where you'll apply the crystal violet, the iodine, the 95% ethyl, do the several washings, and finally apply the safranin for you to differentiate between the gram negative and the gram positives. But how long does this process look? Again, depends with the individual experience on how to do the process, the delays, the overstaining, how old is the stain, how good quality is the stain, and so on. Now, if you come to the next procedure, the standard testing, again, you look at the manual methods vis-a-vis the automated method. So under the manual methods, we look at the culture, the biochemicals, and we look at things to do with the catalase test, the lactate agglutination. Then, if you look at the current, one of the current techniques, automated methods, we look at the Vitek MS, then we'll compare with the manual way when you're doing culture and so on. So under the manual, you'll see you'll need, of course, to take a colony probably and do the biochemical test. So most of you are already aware with our API technique of doing the biochemical test. This is the different expressions of the organism, which kind of acid probably they produce or the chemicals they produce. And when you do the addition, there's a matrix that is in the biochemical test. You can quickly come up with something like an algorithm where you can quickly now say, this is probably Salmonella, this is Staphylococcus, or this is Streptococcus or something like that. And through that, we check it through carbohydrate fermentation, methyl red, citric acid neutralization, and things to do with hydrogen sulfide production. So we all do this, all incorporated in the API identification from Biomir, although there are other methods which you can do manual. Again, I know when you're talking about latex agglutination, we all know about things to do with catalase. And when a patient serum is mixed with the lactic beads that are coated with specific antibody of the antigen, if the suspected substance is present, the beads will agglutinate. So we all know about this procedure, and we're talking about things to do with CRP. But again, when you're talking about on organism, we'll use catalase to identify the different organisms when you talk about strep and when you talk about staphylococcus again. So exactly, this is what I was saying. So when you talk about catalase, it's a slide method we're using to differentiate between the staphylococcus and streptococcus. So when it's positive, we all know it is staph. So again, and again here we are looking at effervescence, when the bubbles are present. Now, all this method which you're talking about is trying to compare the current method, which is the manual, apart from the gram staining again. Then when you're looking at automated, we have, I'll talk about the recent technology when you talk about the Biotech MS, and this uses a technique called spectrophotometry. And in that case, it's mass spectrometer. And in most cases, we call it a Maltov MS. And in full, that is matrix assistant laser dispersion ionization time, mass spectrophotometer. And our Biotech MS, I know most of you know of Biotech. So our Biotech MS is able to do that using the spectrophotometry. And in this case, the resulting spectrum of the mass distribution will be interpreted according to the knowledge database developed by Biomir. Already, you know, we've been in the market for long, and from the data that we've collected, we are able to give you a specificity of 99.7% on the same. So with them and within the shortest time period. Okay, and again, when you're doing this, it's based on the cell wall of the organism or the different matrices that we've used to identify this. And again, that has been built under that database knowledge. Then we are able to identify it within a very short time, as I'll explain in my next slide. So in this case, when you're doing, you can see how they're moving up. So the laser fires on a sample and creates an ion cloud. Then the ions are related by a magnetic field. So of course, there's something to do with the vacuum, where now it's like a tube where the ions are normally pushed inside by a vacuum. Then the ions are focused into a beam. Then the next stage, the ion beam is steered towards the linear detector, which is actually on top somewhere here. Then the ion gate allows the deviation of the low mass ions. Then the next stage, the ions not deviated by the gate split linear detector, creating a mass signature or spectrum. So that's where you can be able to see, that's where you're able to see these peaks. Then the detection is done. The whole of this process is done actually within few seconds. So you can imagine how fast that can be. Then, of course, antimicrobial susceptibility testing. You know, after you've done the identification, you need to go to the next step and do the detection of the antimicrobial susceptibility testing, do the antimicrobial susceptibility testing. This is whereby you check different drugs against one organism and know which one is the most ideal for this patient or for this organism in that case. Now, if we look at, the current technique, which I was trying to present today, which is called the BioFire BCAD2. So BioFire is a technique where we are using a syndromic approach, And it's a multiplex PCR technique, nested PCR technique, whereby we combine different syndromes and organism and do the identification within 1 hour, approximately 1 hour. So if you look at how you do it, of course, you draw the blood, you do the blood culture. When it is positive, of course, when it flags positive within 12 to 72 hours, although some may even do below that. The other procedures is you can continue with the standard testing, or you can use the biofire route and identify your organism approximately within 1 hour. So you can imagine you will have reduced the time to identification by close to 70%. So the subculturing of the positive blood culture is necessary, of course, to recover organism for susceptibility testing. The epidemiological typing and to identify organism, the blood culture that are not detected by the BCID2. So this is like a disclaimer, of course, you are doing this. This is a PCR technique, but you may need still to proceed with your identification, with your antimicrobial susceptibility testing. So let's look at this panel. When you're talking about biofire BCID2 panel, what does it comprise? Now, if you look at your gram-negative organism, your gram-positive organism, yeast, and 10 antimicrobial resistant genes, you can imagine all this doing it within 1 hour using only 200 microliters of your sample, and you're able to identify all, not, of course, not all, but your major gram-negative bacteria, your major gram-positive bacteria, and yeast cells, and of course 10 antimicrobial resistant genes. I will discuss about the antimicrobial resistant genes in a short while. But basically, what does it comprise when I talk about the BCID panel? This comprises of 43 targets, and you identify all these within 1 hour. The sample size is only 200 microliters of your sample, of your positive blood culture samples, tested as soon as possible, and you're able to identify all the organisms that I've mentioned in my previous slide within that 1 hour. Now, sorry, my slide is. So this is how you collect. You may need a gauge 28 needle. You tilt your positive blood culture. Of course, you need to still consider the pre-analytics. All of you know how to do the blood culture. To do the blood culture. So all those pre-analytics, I'm assuming we've considered. So you collect your sample, of course, at room temperature between 55 to 25 degrees Celsius, and you load it in the system, or the cartridge, then load it in the system. So the system, I'm assuming it looks something like this. Then either of the two. So we have two kinds of different equipment, which I may not want to discuss it right now, but you load it in the instrument and you walk away, come back after 1 hour and get your reports. Now, I know most of you may wonder, how come a PCR takes 1 hour? How that fast, and how are you able to identify within 1 hour all that 43 targets? So this is a DNA, so you have a DNA process control, and as I said, it's a PCR process. Remember, it's a closed system. Inside there, you get all your processes, the extraction, amplification, and detection. The same process that undergoes in the manual PCR procedure is the same process that will be done inside this equipment, but under control. Under control. Inside the testing, we'll have a DNA process control. And when I talk about DNA process control, for organisms that have that are DNA based, the control will check against them. For the organisms that are RNA based, for example, for our other panels, for some of the viruses that are RNA, the cartridge comes with an internal RNA control. So the moment it checks against the RNA, if the combined organism, let's say the target that you're doing, if it's the 43, if maybe one is an RNA and the other is a DNA. So the equipment is able to do, actually is not able, the equipment will be able to do the RNA process. Then when it finishes again, it will do a reverse transcription to check against the DNA process. So that's why we are having also the DNA process control. Then for the PCR2 control, again, you know, these are multiplex technique. So what I mean by the PCR control is the first stage will do a multiplex because these are concoction of different organisms. Then from the concoction of different organisms, whichever organism that will be identified, we are using a technique called the film array. So inside this film array, we have 102 wells that have different primers and of course Masamics that also contain the different primers. So when you do the PCR2 process control is after the stage 1 PCR within the cartridge, it will move to stage 2 process control. I mean, stage 2 of the PCR, and under stage 2 of the PCR, it will now do the singleplex detection. Remember, the first stage was multiplex, where a whole concoction of all the organisms are being detected. Then in stage 2, all the organisms now that have been identified are being given the specific primers and identified individually. Then you get a comprehensive report on the same. So that's exactly what I've explained, and you can see the detection if you have an influenza or something like that, and plus another bacteria within the same sample. So all the targets or all the organisms will be tested in duplicate. So this is a sample report on how the organism will look like. So you'll have your run summary, what was identified, is it which organism was identified, and if there was a resistance from a certain organism, it will tell you which antimicrobial resistance was detected. For example, here it is a CTXM, which could be an extended spectrum beta-lactamase or something like that. Again, the results summary, it will tell you so it will give you a 2-page report. Among the reports, which one was detected? Sorry, I think there's somebody trying to interfere with Mr. Kamau. Okay, so among the reports, it will tell you which ones are being detected, the antimicrobial resistant genes, you can be able to see here. And among the gram-positive or the gram-negative, which one were also detected. So if it was detected, it will tell you detected or not detected. It will give you the run details, was it successful? And for your information, if the control fails, as much as the patient sample went through, all the reports will be invalid. So for example, in this case, this report, you can see Enterobacteriaceae were detected, and also Escherichia coli was detected. And you can be able to see what was positive as an microbial resistant. So for example, if you're talking about Staphylococcus and you develop, maybe this patient has a medication and there was a resistance from maybe methicillin-based medication. So it will tell you, watch out, this patient is positive for Staphylococcus and is resistant to methicillin. So you may be able to know if it's McA or C or MRJ, both are methicillin resistant. So you're able to tell that. Then under the assay interpretation, I'll not dwell so much on this, but when you have the solution, we're able to tell you, or we're able to guide you, or the instrument is also able to guide you on how to do the interpretation. For example, if it's Staphylococcus species that has been detected, or maybe it's multiple species of Staphylococcus that have been detected. So how do you do, how do you do the interpretation? So you are able to be given a guide, or the instrument will also be able to let you know, like, which one do you go with? So for example, in these cases, we are combining the three or four species, different species of Staphylococcus aureus, and We're giving you like an interpretation of the same. So for example, if you have all of them, the 4 of them positive, so which one do you go with? And again, it is good to note that multiple Staphylococcus species assay may be positive in a single sample, as I've just described. And if this occurs, the test result for each species with a positive assay will be reported as detected, because of course, they've all shown that positivity. So again, if you're talking about strep, and in this case, group A, the species assay may be positive in single sample. And if this occurs, the test results for each species with a positive assay will be reported as detected. Again, we can give more explanation on the same. So the report will give you a small interpretation down there just to explain what does that report mean. So all this is collected from the database that we built over a long time. This is a snapshot of kind of exactly what I meant. If you have maybe an bacterial cells detected and plus the other one, so you can see like here enteric 1 and or enteric 2 assay, if it's positive, negative, what would be the description at the end here, or salmonella assay. So what would be the description if these others are negative plus and or if enteric 1 and enteric 2 are positive? So you have like a snapshot description of the same. Now, quickly, let's look at antimicrobial resistant genes and what do they mean. So you've seen the target organism in this panel, gram-negative, gram-positive, the 43 targets, and also we have the yeast. And now we want to concentrate basically more on the antimicrobial resistant gene. So what is the origin of this antimicrobial resistant gene? So majorly we have two, non-genetic and genetic origin. So when you're talking about genetic origin, non-genetic origin, bacteria are walled off within for example, within an abscess cavity that the antibiotic cannot penetrate effectively. Could be a surgical drainage or so. And for your information, I know most of you know the different target sites of different antimicrobial, different antibiotics or antimicrobials. The reason why I'm bringing this is because when we are looking at targeted therapy, yes, you may be able to say, I'll give a broad spectrum antibiotic, but we all know these antibiotics have target sites. So unless you do that targeted therapy, and unless you do that targeted diagnosis where you really narrow down and know it is this specific organism. With this era of antibiotics, when you get to the hospital, I can use an example of, let's say, something like CSF, for example. It's one of the precious samples that we have in the lab. This is a patient that probably has presented with suspected meningitis. You are not sure if it is viral meningitis or if it is bacterial meningitis or it is fungal infection, cryptococcal or something like that. And of course, we know with the case of meningitis, this is like an emergency. So first thing, God forbid, if it's a child, what would be the first case to manage? The first instance will be maybe to get a sample and then meet the patient and start on antibiotic. So what happens probably after 3 days when you as a clinician or as a laboratorian, you get a report and indicate no growth obtained. And already the patient maybe has been administered antibiotic, you see. So the doctor will do, what the doctor will do will be probably stop the antibiotics. But remember, you've already exposed this patient to antibiotics. So that's the kind of urgency we're talking about. So when you talk about blood, especially in blood infection, within that 1 hour, you need to be able to know what am I dealing with. Is it a bacterial infection? Is it a gram negative? Is it a gram positive? Then when that doctor starts the medication, you're able to narrow down and know I'm dealing with this kind of organism. So I'll either use maybe carbamazepine or maybe a carbamazepine kind of treatment, probably it is a Klebsiella, or methicillin-based treatment, or maybe, yeah, or maybe a CTN, or maybe a carbamazepine, or maybe something like vancomycin also. So we need to know at what point we start there giving antibiotics. So when you look at the misuse of antibiotics, which I've already discussed, where do we get these antibiotics from? Example of antibiotic misuse that can lead to antibiotic resistance is consuming outdated antibiotics. You go to the hospital, or you go to a pharmacy, you have a cough, then you're told, no, this cough of yours is getting down, it's getting to, who told you that that cough is bacterial infection? And then you just take an antibiotic, Consume antibiotics for inappropriate condition, just as I've said. Example, common cold. You haven't gone to the hospital, or you have not been diagnosed, you've not been done maybe a lab check to confirm that indeed you have a bacterial infection to warrant you take an antibiotic. You could only find probably just an RSV virus that is just causing the common cold, that is giving a bit of fever, pain, and so on. That does not warrant an antibiotic. Again, not taking antibiotics as prescribed, of course, you've been maybe told to take 3 times a day, you're only taking once, you feel better maybe the first day, and then you decide, it's not making any sense, now feeling better, you stop. Remember, as I said, if we had time, we'd have looked at the different target of these antibiotics. So, and remember, the dosage that you're given, these are studies that have been done, by the time that organism or that antibiotic penetrates that organism and does the effects to the organism, it will take probably these days, and you need this dosage or this load of this drug for it to clear that organism. So it's very wrong when you're given an antibiotic and you just take the first 2 days, you feel, I'm feeling better, you stop it. Or maybe, again, some people may overdose at the same place. Again, consuming antibiotics prescribed for someone else, and you don't know, these are someone probably was diagnosed of a different bacteria or viral or something like that, and yours probably is different, and you tend to share the same medication. So those are some of the reasons. In a nutshell, I also wanted to share the different targets of the antibiotics and what are their targets. For example, if you look at the RNA polymerase, we're talking about rifampicin. When you're talking about vancomycin, for example, so what are we targeting? Is it the cell wall or the nucleus or something like that? So as I said, each antibiotic has a different target. So it's always very important when you're taking that antibiotic or when the doctor is prescribing an antibiotic, it is based on the target organism that has been identified. So in this case, are we targeting the cell wall or are we targeting the nucleic acid? Yeah, you could be taking an organic, maybe a beta-lactam, things to do with carbamazepines, and maybe your organism that has been identified needs some quinolones or something like that. So it's always very good to know which is the target organism, so that that doctor can be able to do that targeted therapy where it hits the organism with that specific antibiotic. We are no longer in that generation where we do the bazooka way. You are just hit with a broad spectrum antibiotic. And yeah, so we are no longer in that generation. So basically what I was talking about these antibiotics, we have those that are depending on the gene coding, could be, especially when I talk about methicillin or penicillin family, the gene coding is MEC-A, MEC-C, or MRJ enzymes. Then also when you look at the genes that code coding for things to do with KPC, BIM, Imenipem, or Octa48-like, or carbamanipins, or gene coding things to do with cephalosporins or something like that. So these are different different antibiotics with different targets. So that you need to be very careful, especially when you're doing the diagnosis. So this is a brief summary of result interpretation for the antimicrobial resistant genes. Again, for this information, we only focus on like the major antimicrobial resistant genes. Remember, we have close to more than 70 to 80 or even more than that antimicrobial resistant genes, but we're talking the most common ones, especially the ones that affect our population. So this does not mean that these are the only resistant genes that we have. There are so many others. And so this one is just to show you the commonest resistant genes which are associated with which kind of organism. For example, when you're talking about MASESE, you see it's more related to Staphylococcus epididymis and leucogenesis. So each resistant genes has its own has like specific organism that is resistant against. So again, if you look at like what I'd already discussed a little bit earlier, when you're looking at methicillin, MRSA, MASESE, and the different interpretation, or how do you like kind of do the interpretation? Like if it is Staphylococcus, not detected. Is it Staph aureus, negative, MASESE, any results, MRJ, any results? So how do you interpret that? So that will be like not detected. If it is Staph aureus, MASESE or MRJ, or rather MRSA, detected, that means that is in Staphylococcus aureus, it will be positive, positive, positive. Again, Staph aureus detected, but MASESE, MRJ, MRSA not detected. In Staph aureus will be positive, MASESE will be negative, MRJ will be negative. So all those is a combination that will help in doing the interpretation and knowing, because if the organism gives, the instrument gives you a positive Staph aureus, then what next? And if it gives you the other species also positive, so how do you do the interpretation of which is as a result of this resistance? So we are able to give you an interpretation of the same. This is just the summary of what I've already discussed on the same. Then quickly, let's look at the key clinical benefits as I summarized. So if you look at the BCID2 panel, and I was not able to put some of the studies that we've done, but maybe when you have time, we can discuss on the same. So we are trying to reduce the time to detection by around 70% reduction time. And if you look at the performance from the studies that we've done and the local study that we've done, we are looking at with 99% sensitivity and 99.8, actually it's 99.4% sensitivity and 99.8% specificity. The BCID2 panel demonstrated good concordance with confirmatory testing in clinical use. Of course, we have some reference. And again, we can see some of the studies that were done to confirm on the same. Time to effective therapy, reduce vancomycin use, and such like things. So finally, let's look at the key points. As I said, this technique does 43 targets in 1 hour. You have one sample, only 200 microliters of the sample, and you can see the performance at 99%. So thank you very much, and I would like to welcome if there are any questions or queries that I can handle. I can see on the chat box. Kamau, are there any questions? Maybe.
Thank you very much. Thank you very, very much. Mr. Edwin Masese, for that insightful presentation. At this point, I would wish to give the floor to Mr. Stanley Mugo. You can unmute yourself and ask the question. Mr. Stanley Mugo, the floor is all yours. You can unmute and ask a question. Once again, thank you very much. One question here, is this technology available in Kenya? Mr. Masese, you could quickly answer that particular question.
Thank you very much. Yes, the technology is available in Kenya. We have it on clinical use on several institutions, and we also have it in research institutions. Yeah, so the solution is available. But quickly looking at the chat box, Mr. Kamau, if you allow me.
Yes, there is a question
yes.
here. Okay.
Yes, I can maybe as I handle it. I can see the question. Will this presentation be available on YouTube on record? Kamau, you can advise, but yes, I can be able to share the presentation. So
it's already on YouTube, and they can be able. We've been live on YouTube and Facebook, so they can always circle back to get more information. And those of you who would wish to get brochures and such like information, use the chat box, share your email address and institution, and we'll be able to push this. Yes, you can proceed with the questions.
Yes, and again, if you have any queries, I know this was just a summary of the whole idea, but we are able to share. I'm available. My colleague, Mr. Kamau, is available. We can be able to give you more details. There's a question here from Sylvia. Good afternoon, everyone. Thanks for this informative. Please share offline. I'll be able to share. Sorry for those who are not clear.
There's a question on how you handle false positives for certain organisms from biofire versus culture, which is presumed to be the gold standard. How do you handle that discrepancy?
Yes, thank you very much. But on presentation, sorry, on biofire, the false positive. So one thing that you need to do, remember, as a disclaimer, when you're doing diagnosis, especially for the doctors, you do the diagnosis where the patient is in front of you. So when you have a false positive on one report, remember, we are saying these are complementary reports to, a complementary results to already what you're doing. So compare all your report with other reports that have been done, the CRP, if you've done the PCT, for example, other markers that maybe you're able to, for example, if it is blood that maybe you use to do the diagnosis of sepsis or something like that. Again, you need to understand the technology. For example, when you talk about biofire, this is a PCR technique. When you talk about the culture, remember, if this patient has been on medication and you do the culture growth, chances are, unless you're using the correct bottles or technique, you may not be able to detect the organism because it will be suppressed by the antibiotics. But remember, when you're doing the PCR, our target is the nucleic acid material. So in this case, there are chances are you'll detect it using the nucleic material, but you can miss it in your antigen antibody agglutination test or in your growth. So the most important thing, if you find such discrepancies, it's always good to compare with other clinical history, the history of the patient, what is maybe the full hemoglobin report indicating, what is the CRP, if you're doing maybe it's a critical patient, look at the PCT levels and make that informed decision from the other complementary results. I hope I've answered that. Unless Is there any other question, Mr. Kamau? I've seen the emails being shared.
Madam Evelyn is asking for a placement option. I'm sure you can take that offline with her. I'm sure you'll be able to discuss that with her. I think for those of you who have shared their email addresses, we will be able to share some information around the same. You can also join the WhatsApp group so that you get real-time invitations when we have sessions. Next week, again, we have another session. Happy if you can share your areas of concern and what you'd like us to carry on this particular platform. We will also be availing shortly CPD points for those of you who require CPD to renew your practice license. So be on standby, that will also be offered. So I'll be sharing the WhatsApp link. You can use it to join the WhatsApp group on this particular chat box and be able to interact with your colleagues. Anybody who has a question, you can unmute yourself, ask the question. We have 6 more minutes before we can close.
Okay, maybe Kamau, if I can quickly let you know that apart from the blood panel or this BCID panel, we have we have other 6 panels that we are able to identify. So we are able to do the respiratory panel where we have 23 targets. You have majorly viral panels, viral organisms and typical bacteria. We also have a pneumonia panel where we are targeting now more of the lower respiratory tract infections, and we're targeting more of the bacteria than the viruses, and 7 antimicrobial resistant genes together with some viruses. We also have a CSF or meningoencephalitis panel with the 14 targets. So here we are targeting bacteria, some viral infection, and Cryptococcus. We've just launched another panel for JI, that is joint infection panel, where we are targeting things to do with orthopedics. We have 39 targets, majorly bacterial infection. Here we use the synovial fluid. And we have the GI panel, which is the gastrointestinal panel that detects 24 targets. So here we are looking at organic bacteria, viral infection, some viruses, and some organisms like what is a parasite also. We've just also got another panel, that is the fever panel, that has the current pandemic, that not pandemic as such, but Ebola, Marburg, malaria, chikungunya, and such like. We are targeting to get new panels with STI and the UTI targets also. So very soon you'll be able to see more of this. So if you have more information, I'll be sharing my email also. You can ask your questions. We can plan, we can do demos, and we can discuss more on the same. So I'll be sharing my email in a short while. In case you have questions, we can discuss more. Thank you very much for your participation and for your compliments from the chat box. And I think I'll hand it over back to Kamau.
Well, thank you very much, Mr. Edwin Masese, for that very insightful session. We feel enriched and more knowledgeable in the area of molecular laboratory medicine. We look forward to many more engagements. And at this point, I want to thank all the participants online and also welcome you to share areas that you wish covered. It could be in the area of external quality assurance, might not be always be science. We could also delve into areas of leadership and management, advocacy. How can the laboratorians advocate for more resources within our facilities? These are all topical areas that we could use to enrich ourselves and become better in this very competitive world. So over to you guys. Enjoy your weekend. See you soon. And thank you very much for your time. Asante sana.